topic of today's session is unconsummation of marriage. Here's a brief introduction before we start the session.
So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as a local session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event called Neonatal Pathshala series, hosted by the National Neurology Forum, Gujarat State Chapter. And the focus of today's session is case presentations on persistent pulmonary hypertension of newborn. Now, without wasting any further minute, let's begin today's session. I would like to invite Dr. Kunal Ahia, sir, the Honorable Secretary of the NNF Gujarat Chapter, to start the event today with his enlightening words and for the further coordination. So, over to you, sir. Kindly proceed.
Thank you, Ritu, for the platform. So it gives me immense pleasure to continue with our neonatal Pathshala series. So today we are having a very interesting case on pulmonary hypertension, for which Bhavya will be presenting to us the case. And Binoy has excellently mentored Bhavya, and so it will be a very interactive and a wonderful session. For experts, we have Dr. Kavita and Dr. Sandeep with us. So thank you so much, everyone, for being there. So before starting the session, I would request Shwetal ma'am to say a few words.
Thank you, Dr. Kunal. Not wasting much time. It's really glad to have Bhavya on this platform as a fellow of neonatology. It was just few months or a year ago. He was with us as a resident. So best of luck, Bhavya. And it's a pleasure to have Dr. Kavita and Dr. Sandeep with us as an expert faculty. Over to you, Dr. Vijay.
Thank you, madam, and thank you, Kunal bhai. So, in today's neonatal Pathshala, we have a case presentation on persistent pulmonary hypertension of newborn, and it will be presented by Bhavya Patel, who is doing his fellowship in neonatology at Arpan Newborn Care Center, and his mentor is Dr. Binoy bhai, who is a consultant neonatologist at Arpan Newborn Care Center. In our today's case discussion, we have two experts. One is Dr. Kavita Sri Kumar madam. She is a consultant neonatologist and associate professor at Goa Medical College. She is a course coordinator for fellowship program, and she is also secretary at Goa NNF chapter. She has a many publication in national and international journal. So I welcome Dr. Kavita madam. Our second expert is Dr. Sandeep Tilwani, who is a DM neonatologist, and he is an assistant professor at Adani Institute of Medical Science, Bhuj. He is faculty in various training program, and he has also many national and international publications. So I welcome Dr. Sandeep Tilwani, sir. So Dr. Bhavya, I think you can proceed now.
Sure. Good afternoon, one and all. Myself, Dr. Bhavya Patel. Okay. Myself, Dr. Bhavya Patel. I am presenting the case of PPHN under the guidance of Dr. Binoy Sir. My presenting case is the case of a male neonate of baby of XYZ. The gestational age maturity was 39 plus 5 week. Mode of delivery was LSCS delivered. Birth weight was 3.25 kg. Baby was referred to our NICU on the 8th day of life in view of the PPHN with ventricular dysfunction. Coming to the antenatal history part, mother was 23-year-old, gravida 2, para 1, abortion 0 and live birth 1. Pre-pregnancy weight of mother was 52 kg. Mother blood group was AB positive. In the first trimester, mother was booked case at private hospital and taken regular antenatal visit at monthly intervals. She tested negative for HIV, HbSAg and VDRL. Folic acid was taken regularly. First trimester scan was normal. No history of fever, race, lymphadenopathy, drugs and radiation exposure. Coming to the second trimester history, there was both iron and calcium tablets were taken regularly. First dose of TD was taken at 16 week of gestation and the second dose was taken at 24 week of gestation. A USG scan was done at 20 week of gestation, which was normal. Coming to the third trimester history, antenatal visit were taken every 15 days at nearby private hospital. Mother's weight was increased up to 63 kg. Third trimester USG scan and the Doppler was done at the which was normal. No history of fever, burning, micturition, convulsion, foul smelling, discharge, leaking, or bleeding per vagina was there. Coming to the postnatal history, as per the referral note from the referring NICU, the baby was LSCS delivered, cry immediately after birth, had meconium state liquor. Baby required surfactant therapy, conventional ventilation followed by the HFOV ventilation, IV fluid, IV antibiotics, milrinone and sildenafil at the referring NICU. TD echo done there was suggestive of the PPHN with ventricular dysfunction. The vital parameters on receiving was temperature was 36.2 degrees Celsius, heart rate was 172 per minute, respiratory rate as patient on HFOV, CRT was 2 seconds, SpO2 there was preductal 84% and postductal 74%. SpO2 was there. Pulses was well palpable in all four limbs. RBS was 84 and the invasive BP monitoring suggests 68 by 37 and the mean BP was 48 mmHg. At our hospital, the baby scores is like following. Baby was kept on the HFOV on receiving with FiO2 requirement of 100%, amplitude kept 30, MAP was 16, and the frequency kept 8 Hz. Blood investigation were sent and IV fluid with calcium started. Blood CS sent and antibiotics continued. On receiving first ABG done, which was suggestive of pH 7.1, PCO2 54, PO2 lower side 57, BiCup was normal 23.4. So according to that, OI was 28. Blood report, routine blood report done, which suggestive of the HB 13.5. Otherwise, CRP was quite higher side 28.5. Our first X-ray on receiving was changes suggestive of the meconium aspiration syndrome SC, bilateral floppy opacity is there. Along with there is the ET2 in situ between the T1 and T2, and otherwise UAC and UVC was in situ there. We have started INO considering this OI and as well as the FiO2 requirement. On receiving, we have started with the 20 ppm injectable milrinone at 0.2 mic and the injectable atri at 0.1 mic was started. For sedation, we preferred injectable fentanyl at 1 mic per kg per hour. 2D echo done at our side was suggestive of PPHN with right ventricular hypertrophy was present. After the starting the INO at the 4th hour, we have repeated the ABG, which was suggestive of the 7.29. PO2 was improved than the previous one, 129. Otherwise, PCO2 was 41. BiCup was 19.2. Base excess minus 6.9 and the OI kind of decreased up to 8 point. Vitals at the 4th hour of INO was SpO2 improved to preductal 93 and postductal 85. Ultimate difference has been decreased. IBP was 62 by 32 by 49. Considering that FiO2 tapering has been started, INO also tapered at 4th hour of the starting INO up to the 10 ppm. As FiO2 requirement almost decreased to 60% and PO2 improved more than 60 mmHg, and which lasted for the 60 minutes. Now then at the 9th day of life, FiO2 continued tapered up to 50%, which after tapering INO as per protocol, we have done the repeat blood gas, which was suggestive of the 7.3 pH, PO2 was almost 134, considering it OI was 7.1. So and vital as well maintained after tapering INO from the 20 to 10 ppm, which was preductal 94, postductal SpO2 88, and IBP was 66 by 34 by 50. Considering it, IV milrinone at 0.2 mic per kg per minute continue and IV adrenaline at 0.1 continue. Considering tapering of the INO, we have started with the tablets sildenafil for the short transition as well. Hospital course on the 10th and 11th day of life. INO was continued at 10 ppm as the FiO2 was between 55 to 60 only. So HFOV has this setting like MAP 14, amplitude 28 continue. Preductal SpO2 was 94, postductal 91. So and adrenaline was continued at 0.1 mic per kg per minute. And considering improving physiology, we have omitted the injectable milrinone. After that, one ABG has been done, which was quite improving state. 7.43 was pH, PO2 68, PCO2 33, and the OI considering it 8.2. At the 12th and 13th day of life, as FiO2 decreased to 30%, MAP was 12 and the amplitude was 28. ABG at 12th and 12th day of life has been repeated, which was quite improving with PO2 61 and the OI was 5.9. As FiO2 requirement decreased, blood gas and OI improved, iron was tapered gradually as protocol and gradually omitted at 13th day of life. IBP monitoring with this was normal, and considering it, injectable adrenaline omitted as well. On the 14th day of life, baby was taken to the conventional ventilator SIPPV mode with FiO2 25%, pressure was 16/5 and I time was 0.45 second. ABG after the weaning up to the conventional ventilation, which was almost near normal, 7.44 pH, PO2 66, PCO2 32, bicarb 21.5 and base excess minus 2.2. At 16th day of life, we have extubated baby on HHFNC as FiO2 was around 25 to 30 and the flow requirement was 8. ABG done after extubation, which was suggestive of almost normal, 7.45 pH. PO2 was quite 47, PCO2 43, bicarb 25.5. On the 17th day of life, HHFNC omitted as well and kept on the O2 prongs intermittent with breastfeeding introduced. As at 20th day of life, there is no O2 requirement. Tablet sildenafil omitted as well. As baby was taking feeds orally, remains off oxygen, euthermic and euglycemic on the feeds. Baby was discharged on the 22nd day of life. This is the serial blood gas monitoring, which we have done over the period of time. On the receiving ward, the 8th day of life, there was the PO2 quite lower side 57 with respiratory acidosis and PI was more than 25, almost 28. With ADO2 difference was 432. And at the 8th day of life, after the 4 hour of the inhaled nitrate, there was PO2 improvement as well as OI has also improved. With ADO2 so abnormal, but has been in the state of the improving. And this is how after continuing the management, how the OI thing was improved under improvement. At discharge, baby is examined under the proper aseptic precaution under a servo controlled warmer and on the room mat. Temperature was attached on the right lower part of chest, saturation probe attached on the right hand. Vital parameters are like this: 36.8 degree temperature, 140 heart rate, CRT was normal 2 seconds, IBP was in the both limb was normal, respiratory rate was 56 per minute, SpO2 was 94 in the right limb and the 96 in the lower limb. There is no pyloricterus or the any abnormal finding was there. Anthropometry was done, which weight was 3.2 kg, which was according to intergot 21st start 10 to 15 centile. Length was the 49 centimeter, which was also 10 to 15 centile. Head circumference was 34 centimeter, which was also 10 to 15 centile. This is how intergot goes. Head to toe examination done, no swelling overhead noted. Anterior frontonale was 2 by 2 centimeter open at the level. Posterior frontonale just tip of the finger administered. No facial dysmorphism. Red reflex was bilaterally normal. Ears normal in size, shape and position. No cleft plate, no cleft. There was no any birthmark or injuries, no septum, ala and bridge appears normal. There is no swelling around neck, no polydactyly or syndactyly. Back and spine was normal, anal opening present and patent. Genitals were normal. Bilateral lip examination was normal. And coming to the systemic examination, starting with the respiratory system examination, there was no septal deviation or block, no pooling of secretion was there. Bilateral symmetrical chest rise was there, no signs of respiratory distress. And coming to the central nervous system, I had examined when the baby was not crying, spontaneous movement of all four limbs were present, normal posture, bilateral limb inflection, and lower limb with slight abduction. Tone. Yes.
I would just request if there is anything abnormal, you focus on that. If everything is normal, I think you can skip the normal part so that we can start the discussion.
Yes, sir. There was an examination was normal, especially neurodevelopment examination done, which was almost normal. So coming to the part of the summary, the 8-day-old male unit LSCS delivered from the primary mother with no significant obstetric antenatal history was referred to us for the management of PPHN with ventricular dysfunction, secondary to meconium aspiration syndrome, requiring history of surfactant, HFOB, IV antibiotics, and the IV fluid and referring NICU. We have offered inhaled nitrate for the 5 days, injectable milrinone and adrenaline was given, antibiotic was continued, baby extubated on HHFNC on 16th day of life and discharged on 22nd day of life. Coming to the diagnosis part, this is the single full-term 39 plus 5 acre 3.25 kg appropriate for dead baby with meconium aspiration syndrome and severe PPHN requiring inhaled nitrate. Coming to the discharge advice and the follow-up, we have advised to continue breastfeeding and the Vita Nova D3 supplements. High risk follow-up was explained. BERA was planned at 3 months as OA done at discharge was normal. Neurodevelopment follow-up at the 3, 6, 9, 12 month was planned, and the ROP examination at 4 weeks explained. Thank you.
Okay. Yeah. So this baby was referred to your center at 8th day of life.
Yes.
Right. Okay. So first thing, I mean, do you know the reason why there was MSL? I mean, since the pregnancy was totally this thing, there were no events in the antenatal period. Okay, as per you, there were no risk factors. There were no events in the antenatal period. Did you just go back and cross-check why there was MSL? I mean, why did the baby land up with a meconium stain like that? Because in an otherwise well pregnancy and 39 weeks plus 5 days, otherwise healthy child should not land up with MSL. So, I mean, I would just be curious to know why the child ultimately landed up with MSL. I mean, what was the antenatal event?
Those are there was no any significant antenatal event which can lead to the kind of MSL delivery. So,
So then, I mean, that is not connecting the, yeah, I mean, so, I mean, your case is managed very well. I mean, there is no doubt that the case was managed perfectly, right? But since we are in an academic discussion, I mean, I would like to start from the antenatal part or like what happened at the time of birth, right? So to connect the dots, because see, I mean, as per your presentation only, you're telling that maturity is fine, the child was totally fine in the antenatal period, everything was okay. Okay, so I mean, our job does not start once the baby is born or once the child came to you. I mean, you need to find out the history also, no? Because you need to find out the reason. I mean, why did the child went in for an MSL? I mean, what was the event which led to MSL? Okay, so that is one thing. Maybe next time or after the discussion is over, you just go back and try to get the details because otherwise, healthy child should not, land up with this problem, right? So try to get the details as to why was there MSL. Okay, what was the event which ultimately MSL? What does it suggest? I mean, the child passed meconium in utero, right? So what does it suggest? What does it suggest?
There was chances of intrauterine hypoxia or like a post-term delivery or anything which can lead to the event of the meconium stain like that.
Yeah, so there was some stress in utero. Okay, there was some stress in utero which has led to this. So, I mean, as somebody who is treating the newborns, our job starts from there, right? That from the antenatal period, I mean, what went wrong, we need to find out. Okay, so that is one thing. Second, so this baby, when it was born, what was the initial support given at the time of birth? I mean, you have not mentioned whether the child cried at birth or not, and whether the child required intubation in the delivery room, or I mean, was it a vigorous or non-vigorous MSL? So I would be interested in that.
Sir, baby was, as per the referral note, baby was LSCS delivered, cry immediately after birth. And considering the meconium stain lighter and the impending respiratory distress, baby was required surfactant therapy as well as conventional ventilation at the referring NICU at the first day of
Okay. Okay. So, what is the pathophysiology of meconium aspiration syndrome? I mean, this is MAS leading to PPHN, right? So, what is the pathophysiology? How does MAS lead to this thing? What happens in MAS?
In the MAS, ultimately there was one thing is the surfactant was out, which ultimately to hypoxia and the next cascade of the metabolic acidosis as well as the triad of the PPHN. Along with that, there can be the pulmonary vascular remodeling, which can also lead to the PPHN. So ultimately, the PPHN from the MAS is the secondary PPHN, which was occurred due to the overall maldevelopment of the pulmonary vasculature.
Okay, so I mean, they have given surfactant in this case. So for all MAS babies, you will give surfactant?
No, sir. Evidence not suggests that we should not give in the every baby. But considering that it led to the quite decreasing the days on the ventilator and ultimate outcome, that's right. Otherwise, there is no difference much in the mortality according to evidence.
Okay. No, so I mean, see, you have a baby. Suppose you go to attend a delivery, and the baby is born through meconium strained liquor. Just for an example, say the baby didn't cry at birth and required intubation in the delivery room. You have intubated the baby for being born through meconium strained liquor, okay, and not cried at birth. Now you shift the baby to your NICU, and when you keep the baby on ventilator, this thing, the baby is requiring a pressure of say 22 and this thing PWP of say 5, 6, 6, okay, and FiO2 requirement is somewhere around 100%. Okay, so would you give this for baby?
Yes, sir, we can give you a chance to giving the surfactant therapy. Considering the kind of situation, baby's OI will be on the higher side. So once we took the ABG and we can calculate the OI. If the OI was on the higher side more than 25, then we should go for that is surfactant therapy.
Okay, so do you know any guideline which suggests the indication for this thing? I mean, recently, I think 2 years back, our NNF India came out with a CPG guideline. So do you know what cutoff they have suggested for giving surfactant in MAS babies?
In the MS baby, if the baby is on the invasive ventilation and having the FiO2 requirement as well as the OI on the higher side more than up to more than 15, then we should prefer giving surfactant.
Okay. How much FiO2 and how much OI?
More than 40% FiO2 and OI more than 15%. 15.
Yeah. So FiO2 requirement, which is more than 40% and OI, which is more than 15, that is an indication for this thing. Second thing, what I wanted to emphasize is that see even if the child is having an FiO2 requirement of 40% and you feel there is some PPHN component and MSL history is there, not necessarily all babies would require surfactant. Okay, it can be like your meconium, if it goes inside the lungs, if it is causing surfactant inactivation and because of that you are having patchy heterogeneous opacities in the lung, or maybe you are having low volume lungs, then you are justified in giving surfactant, right? But if it is MAS, but your lungs are totally black with expansion which is good, okay, then in that case you don't need to give surfactant, right? So that is one thing you need to know, that surfactant, I mean, it is not for that all babies which are requiring oxygen would land up with surfactant. Okay, you have to take into account all the things. Second is you told the child was kept on high frequency ventilator. So what are the indications for starting HFO in this case?
HFO we started as the MAP was on the higher side. HFO, the patient already having the respiratory failure on the mechanical ventilation, conventional mechanical ventilation, and considering that HFO was preferred, and as well as there is the pathology of meconium aspiration syndrome, HFO can also be preferred instead of conventional ventilation, considering the risk of the air leak and all things.
Okay, so right, for all this thing meconium babies, HFO would be useful, or there are certain set of babies where you would want to use it?
No, sir. That is also if the baby is quite doing well on the conventional ventilation and the blood gas as well as the overall clinical picture was under the control, then we should continue with that. But even up on the conventional ventilation, if the requirement of FiO2 was on the higher side, the ABG is considering the persistent respiratory acidosis hypoxia, then and OI is on the higher side still, then we can give for chance to the HFO ventilations. And
okay, so even if the lungs are totally black, suppose your child is having PPHN, okay, your child was born through meconium strained liquor, and the lungs are otherwise black, okay, the chest expansion is good, and the child is now having PPHN, okay, and requiring, I mean, even with 100% oxygen, the pre-ductal saturation is around 85, 86. With conventional ventilation of PIP of 25 and PWP of 7 or 8. Okay, so would you go for HFO? Because now your lungs are otherwise well expanded, right? So, I mean, HFO stands over this thing, conventional ventilation, when you want to deliver extra mean airway pressure, or right. With conventional ventilation, you have a limitation that you cannot go beyond 10, 12, or sometimes beyond 13, 14. Beyond that, there is a chance that there may be high chances of air leak. With HFO, you can deliver those higher mean airway pressures, but it is relatively safe. The chances of trauma would be less. But then in this case, already your lungs are well expanded. Then, I mean, are you justified in shifting to HFO, or is there something else which you want to do?
Considering that if there is the lung is well expanded, so there is no extra MAP required. If we are achieving the MAP that required with the conventional ventilation, so no need for the go to HFOB. But instead we can, if the baby is PPH, and we can think of the inhaled nitrate in that case as well with conventional ventilation.
Okay. Okay, so that only that HFO is not necessarily required for all the babies. Okay, if you have a problem with the recruitment of the lung, okay, then maybe HFO stands out over conventional ventilation. But if your lungs are already well recruited, I mean your lung expansion is good on X-ray, HFO may not make much of a difference, right? So that is the point I wanted to emphasize. Okay, then so you start. I mean, this baby was started on HFO in the other setup, no, before being referred to your center.
Yes, yes, sir.
Okay, so what were the settings on HFO where it was started when it was started?
Sir, there was the HFO.
And I mean, HFO was started on day one itself, or later.
No, sir. HFOV was not started at the day one. Initially, they was offered the conventional ventilation for 48 hours, and later on they was started with the HFOV.
Okay, so I mean, if you go by the history, I mean, it is not correlating, right? Because if there was a problem with the recruitment of the lungs, okay, that should have been done on the first day itself. Okay, I mean, it is not criticizing the other unit. I mean, I'm just telling, because as per the history, I do not know. I have not seen the case. So what has happened, it is difficult to say retrospectively. But as per the history which you are telling, so I mean, as per the history which you are telling, it seems that first 48 hours they gave a trial of conventional ventilation, then they shifted on to HFO. But I mean, if the problem was with the recruitment of the lungs, then HFO maybe could have been started earlier, right? Because ultimately the target is that you want to recruit the lungs fast. If you wait for 48 hours, already some decompensation might have happened in those 48 hours. Okay, and since they had given surfactant, I hope they would have given surfactant on day one. So they have made an attempt to recruit on by giving surfactant on day one. Then HFO on day three doesn't correlate well, right? So that is one thing. Second, my concern is, I mean, the child was referred to your center on 8th day of life, right? So that is quite late. I mean, usually if it is PPHN and all those things, it should be fast. Okay. So, I mean, they referred the child quite late, I feel. But again, I mean, that is okay. I mean, since I have not seen the case, so maybe that is a point I wanted to emphasize. Then regarding HFO, how does it, how is it different in terms of settings? Or what are the different parameters you set when the baby is on HFO?
HFO. Sir, sorry, sir.
Yeah, so there are five parameters you would like to set, right? What are those five parameters?
Yes, sir. So we have to set up in the HFOV. The first is the MAP. We will prefer that the baby record on the CMV, the two higher than that, we will MAP at the HFOV. The frequency in the full term baby, we will set around the 8 to 10 hertz. In the for the preterm baby, quite higher, 10 to 12 hertz. FIR2 as per the requirement, and was watching the SPO2, we will set the FIR2. The amplitude will be the setup almost twice than the MAP, and we will watch for the chest wiggle and up to umbilicus, we will see the wiggle is there or not. And the last one is the inspiratory gem expiratory ratio as per the clinical situation, either 1:1 or the 1:2 I/E ratio. We should start with that.
Okay, so I mean, so these are the five parameters which you told me. Now, how superior, or how is HFO superior to conventional ventilation as far as controlling oxygenation and CO2 elimination is concerned?
Considering oxidation and CO2 elimination, there is the first advantage is that it is separately manage the ventilation and oxygenation part. So we can target the parameter according to that like only. And another advantage is it have the multiple actions, so the well recruit the alveoli, like it have the collateral ventilation quality as well as pendulum mechanism of action, asymmetric velocity profile. Kind of this mechanism of HOPO we prefer for the non-recruit alveoli. So ultimately, when there is the lung pathology or the lung collapse, this kind of mechanism helps us to recruit the lung and decrease our pathology as well. So this is quite HFOV's advantage over the conventional ventilation.
Okay. So which are the parameters for oxygenation and which are the parameters for CO2 elimination?
For the oxygenation, one is the MAP and second is FiO2. And for the ventilation, the parameter will be the frequency and ultimately the amplitude and the tidal volume, which we are going to deliver.
Okay. So can you control the tidal volume which you are delivering with high frequency ventilation?
Yes, we can control the tidal volume. By increasing amplitude, we can increase the tidal volume, and by decreasing frequency, we can increase the tidal volume, and the vice versa as well.
Okay. If you want to deliver a precise tidal volume, is there any mode or is there any new addition
Yes,
which
we can add the volume guarantee with HFOV as well, so we can achieve our desired tidal volume.
Okay. And okay. So yeah, so this is how HFO stands above conventional ventilation, because you can control both oxygenation and CO2 elimination separately, right? Then other things which you said was they had started milrinone and sildenafil in the private setup before the baby was referred to your setup, right? If I'm
Yes.
not wrong. Yeah. So how does milrinone help in PPHN and how does sildenafil? Okay. Or before that, before we go to that, how do you diagnose PPHN? I mean, okay, the referring center referred the baby to you as PPHN, but if you are the primary person treating that baby, how would you diagnose PPHN?
One will be the clinical criteria. In will be we see the classical SpO2 difference of the preductal and postductal. That is also not that at 100% that will be present. If PDA is close, then that difference will be not there. Otherwise, we will look for the labile desaturation or labile saturation difference will be there as per clinically. To differentiate PPHN to the cyanotic heart disease, though this is absolute, but hyperoxia hyperventilation test can be given. After that, in the cyanotic heart disease, there will be no PO2 improvement, but in the PPHN, quite improvement of PO2 up to 100 to 150 mm HG there. And the coming to the criteria of the echocardiography, we can from the echocardiography bedside we can
Okay. Clinically, one more thing which you could see. I mean, not very commonly seen, but again, you have to look for. I mean, because we are in an academic session again. I mean, if you have to look at the baby bedside, maybe I would not see it most of the times, but because this is an academic discussion, what else? Clinically, one thing you told is labile oxygen saturations. Okay. Second is preductal postductal saturation difference. Okay. Those two things are accepted. What else?
Otherwise, clinically systolic murmur can be present due to tricuspid regurgitation.
Due to tricuspid regurgitation, you can get a systolic murmur. One more thing.
Gallop rhythm can be present considering the
okay.
high
Sometimes you may have a single S2 or a loud S2 may be heard. Okay. Though, I mean, most of the times we don't use a stretho to see the loud S2 in the newborns, but it is one of the theoretical points since you are in an academic discussion. And one more thing is the distress or the tachypnea would be out of proportion to your X-ray findings. Okay. Exactly. So that is one more thing which would point towards the development of PPHN. So that is one thing. Second, this thing based on echo, how do you say?
Based on the bedside echo, one we will see the TRZ will be present. There was the straightening of the interventricular septum as well as the decept interventricular septum, as due to the right ventricular hypertrophy. The interventricular septum will be deviated toward the left ventricle. This thing we can see. Along with that, there will be clinically RA-RV dysfunction. Echocardiographically, we can see the RA-RV dysfunction, and later on the LA-LV dysfunction can as well seen. Along with that, we can see the shunt of the PDA as per the how severity of the PPHN is there. Like In the severe PPHN, there will be the right to left shunt. In the kind of the moderate situation, there will be the bidirectional shunt, and the mild PPHN, there will be the right to left to right shunt will be there. So ultimately, considering suprasystemic systemic pulmonary pressure, there will be the shunt direction will be there. So this kind of thing we can see in the 2D echo.
Okay. So one thing is you will see the shunting at the level of PDA, right? And what is the other level at which you will look for shunting?
PFO. Second one is the PFO. There will be often there will be right to left, and sometimes bidirectional shunt will be there at the PFO.
Okay. So one thing is you have to look for the shunting. Second, you told is you have to look for the tricuspid regurgitation jet. Okay, TR jet.
Yeah.
Okay. Other than that, any other thing, any other markers? One more you told is the D-shaped interventricular septum or bulging of the septum in the LV cavity.
Yes.
Okay. Okay. Other than that, any other markers?
Other than that, we can look for the PA pressure by measuring the TR jet, and we can apply the formula of 4 multiplied by TR square plus mean right arterial pressure. By doing the pulse wave Doppler, we can at least know this parameter. If the ultimate pressure we got will be higher than the our systemic pressure, then the PPHN is quite severe. So we have to treat accordingly.
Okay. You know something about IVRT? IVRT and PAAT, anything about that?
Yes, yes. IVRT we can see for the patent artery versus PDA. In the case of there, if there is the shunt is quite on the higher side from the right to left, then it will be IVRT will be on the higher side, and for the shunt which is vice versa, then the IVRT will be on the lower side.
Okay. And what is PAAT?
Sorry, sir, I don't know.
Okay, so go and read about it. Yeah, it is pulmonary arterial acceleration time. Okay.
Oh,
So yes. Okay. So okay. So once you have diagnosed PPHN, okay. So I give you a scenario. Like you do an echo for this baby, and supposingly at the level of PDA, your shunt is right to left. Okay, and at the level of PFO, your shunt is left to right. So what
yes.
does it mean?
That ultimately means the ultimate pulmonary pressure is on the higher side, and there is the quite like ventricular RV dysfunction has been there. So in that condition, this kind of scenario has been.
No, so see, I mean, if RV dysfunction is there, and if the pulmonary arterial pressures, if the right side pressures are higher than the left side pressures, your shunt will be on both the sides at both PFO and PDA. It should be right to left. Okay, but in this scenario, your shunt at the level of PDA is this thing right to left, but at the level of PFO, you are getting a left to right shunt. Okay, what it may signify? Should it alert you or you should be happy?
We should at least look for some cardiac etiology, which is
Okay. So it should actually worry you because maybe now the child is going in for LV dysfunction. Okay. So initially at both PFO and PDA levels, your shunt should be right to left. Once at the level of PFO, if your shunt is going for left to right, maybe now the left side of the heart has started to fail and now you are going for LV dysfunction. Okay. So that may be a worrisome finding, right? Okay. Then coming to the treatment part. I mean, before the baby was referred to you, the child was referring or receiving milrinone and sildenafil both. Okay. So when do you use sildenafil and when do you use milrinone?
Yes.
For listening PPHN?
We prefer the milrinone when there will be the ventricular dysfunction specifically, and the sildenafil when there is the PPHN is there, but ventricular function is quite well, so we can go in that cases with the sildenafil. Otherwise, sildenafil can be used when we are tapering with the inhaled nitrate. So it quite stops the transition, as well as if ion failed to deliver, then in that cases as well sildenafil can be used.
Okay. So a little bit about the this thing pathophysiology of PPHN.
Can I interrupt, Dr. Sandeep?
Yes, ma'am.
We have Dr. Kavita
Yes, ma'am.
with us.
Oh, okay.
Dr.
Sorry.
Kavita?
No, no, it's okay. Dr. Sandeep, you carry on. I'll add on the questions
Yeah.
later. I think you're doing.
Okay, okay. No, we have till only 4 o'clock, so I thought I should interrupt. Sorry, Sandeep.
No, let him complete his like doing the treatment part. So then I'll add on some
Yes.
questions. That's
Okay,
Okay.
okay.
Yeah.
yeah, Dr.
Okay. Sorry, ma'am. Just
No
5 more
problem.
minutes. Okay. So, yeah. So coming on to this thing, pathophysiology of PPHN. Like, what are the 3 different this thing mechanisms by which a baby may develop PPHN?
Sir, three main mechanism are the one is the maladaptation, second is maldevelopment, and third will be underdevelopment. The fourth is miscellaneous like mechanical factors like polycythemia, which rarely can lead to this, but the main 3 are the above 3 mechanisms.
Okay. So, what happens in maladaptation, maldevelopment, and underdevelopment?
Yes, maladaptation, which mostly occur due to the patient was not having the soft transition at birth. So the ultimately the maladaptation occur at the pulmonary vasculature, and there will be the all the things like the remodeling, which ultimately lead to hypoxia and the cascade of the PPHN. This kind of thing in the maladaptation occur. In the development, there will be there is the some developmental issue while they're developing the tissue like the alveolar capillary dysplasia kind of genetic things which is considering the maldevelopment part, and in the underdevelopment part there is like the CDH, so the lung wave was not well expanded, and as well as the preterm premature rupture of membrane, which lead to ultimately oligohydramnios and the pulmonary hypoplasia, and which ultimate continue with the cascade of the PPH. And so these 3 different kind of the physiology can be there with the PPH.
Okay. Okay. So, how does knowing the pathophysiology help you in the treatment? I mean,
Yes.
like if you know what is the main reason, how does it help you?
Considering pathophysiology, we can guide the treatment as well as we can know the prognosis as well. Like the maladaptation having the kind of the severe PPHN, and the kind of the prognosis is not as good as the like other two pathology. Considering treatment part, we can prefer in the underdevelopment part. In the underdevelopment, we should prefer with the proper ventilation strategy like the HFOV as well. In the like CDH, we should at least continue with the HFOV, and we should at least avoid the inhaled nitrate if possible. Like in the mild development and the underdevelopment thing, we can follow the ventilation strategy like that. So ultimately, this affect the severity, prognosis, and as well as our plan of the management as well.
Okay, so if it is maladaptation, I mean, just to add on to that, so maladaptation usually happens because of defect during the transition. Okay, which most likely has happened in your baby also. In this baby also, there was some problem with the transition because he had MSL, hypoxia, something would have happened, and there was reactive vasoconstriction. Okay, so maladaptation is most of the times reactive pulmonary vasoconstriction, which will most of the times or which is expected to respond nicely to your inhaled nitric oxide. Okay, but if it is mild development, which would happen more commonly in a baby who is severely growth restricted. Okay, so if you have a severe fetal growth restriction, and because of that pulmonary vascular remodeling has happened in utero, those cases may not respond properly to your this thing INO. Okay, and similarly sildenafil. And again, if you come to the underdevelopmental part, which is most likely happens in CDH, as you said, in that case, again, you don't expect your INO or sildenafil to act much. Okay, so that is why knowing the pathophysiology, probable pathophysiology, would be useful to guide the treatment and to tell a little bit about the prognosis. Just last one more question. What is the 20-20-20 rule? I'm sure you would be knowing it, but for the other participants.
Yes, 20-20-20 rule is the about how the PPHN baby has been responded. After the 20 minutes of the starting INO at 20 ppm, if 20 mm of the PO2 has been improved, then the baby is the completely responded with our INO treatment.
Okay, so that is one part of the 20. That is, you start the INO at 20 parts per million, and you would assess the response by increase in PO2 of 20. What is the third 20?
Third 20 is at that 20 after the 20 minutes we will that. And
no, it is the oxygenation index of 20 at which you start IN. Okay.
IN.
Okay. Yeah, I think I'll hand over to ma'am for the rest of the session.
Yeah. So Dr. Bhavya, well presented and a well managed case as well. I think most of the things are already covered in the good discussion that we had. I just want you to give me history. Now you already know this child is a PPHN, right? So when you know this child he has been referred to as primary hypertension. When you go to antenatal history, can you tell me some 5-6 points in the antenatal history that you will specifically ask related to PPHN?
Okay.
What do you want to focus on? Some of the things but I want you to tell me the rationale behind asking those things.
Yes, for the PPHN, for the antenatal risk factor, there is quite some specific antenatal risk factor. One is if the mother was on the SSRI or the mother was on the NSAIDs. So NSAID can lead to the ultimately the closure of the PD and the whole thing can happen. Other than the antenatal, if there is the mother was having the persistent fever or the mother already having the hypertension, this can sometimes also be the risk factor. And overall, if the mother is asthmatic, then there will be chances of the PPHN can be also there. So these kind of some factors are antenatal risk factor for the PPH. And other is the
asthma. Can you elaborate on asthma? Why would asthma cause PPHN, baby?
ultimately the one thing asthma can do is considering it in the mother, there will be the uteroplacental insufficiency can be there if it is active, which ultimately due to the IUGR baby and which ultimately maldevelopment part. So
So it can be any reason causing fetal growth restriction, correct?
Yes.
Any reason for that matter, if it causes fetal growth restriction, it is a risk factor for PPH. SSRIs, any other?
SSRI itself there will be the pulmonary vasculature issue in doing the SSRI. According to some studies suggest that SSRI can maldevelopment of the vasculature, which is the reason for SSRI to do the PPH.
So you also pregnancy. So what was the weight in the third trimester then? Why would it be relevant to PPH?
Sorry.
Weight gain during pregnancy. Why would it be relevant in PPHN?
Obesity in the mother can also be the excessive weight gain can kind of lead to the pathophysiology of PPH.
Okay, so when would you say it is excessive then? You know her pre-pregnancy weight 52. What was her weight at the end of the third trimester? Do you know?
Yes, 63 kg was the weight, almost 11 kg weight gain, which was almost normal.
So the opposite also is true. So if she has not gained weight well, then it can lead to growth restriction and then maldevelopment. Yes. When you look at the antenatal scans, what are you looking for?
For the antenatal scan, each 3 trimester, we will look some specific thing. Like in the first trimester, we will confirm the pregnancy first. Then we will look for there is any twin pregnancy or not, which is the ultimate thing we will do in the first trimester. Second trimester scan is the TIFA scan, like the targeted imaging for the fetal anomalies, in which we will look for there is organogenesis issue or any other thing, any anomalies will be there.
Specific to PPH, and what are some of the things you want to look for?
Specifically in the second trimester, we can look for the cardiac there is any cardiac etiology like anything like the dependent lesions or anything we can found in the second trimester TIFA scan. Along with that, in the third trimester specifically, oligohydramnios is kind of the risk factor for this case of the PPHN. So third trimester, there will be the Likert status will be important for us specifically for the case of the PPHN.
Right. There are anomalies you want to see? Which other anomalies can cause PPH and you want to look for?
For the anomaly scan, one is the CDH, then the CPEM, congenital pulmonary alveolar formation. These two is quite significant, as well as the TOPF can also be the due to it difficult transition during the birth, so can lead to the PPHN as well. So these 3 big anomalies we at least see in the case of the PPHN for the antenatal scan.
So congenital heart disease, usually they will not pick up usually on the normal scans. So in which conditions you would ask mothers to do fetal echo? What are some of the risk factors you would consider?
For the
and for fetal echo?
For going to fetal echo, one is considered we have gone for the screening of the trisomies. If the other soft markers of the antenatal scan, it suggests the nuclear transparency on the higher side, short femoral rate, short humerus leg, pelvic testis is there, or there is the intracardiac shadow will be there. This kind of thing will suggest that there is chances of the trisomy or any other anomalies. And as we know, chromosomal anomaly have high chances of that. So in that case, we should prefer fetal MRI. Other than if the previous baby, like the mother having the previous baby with some duct dependent lesion, and if they give consent, then we should go for the fetal MRI for the precautionary purpose in that cases as well.
So even is like artificial reproductive technology technique used, IDM, diabetic mellitus, right? And can, if anything abnormal is seen, if you see one anomaly, you have to rule out another anomaly, so you'll send for renal agenesis. So renal abnormality is also something else which is related to PPH. So you would look on the scan to see whether there was any renal abnormality detected. And like I said rightly, oligohydramnios. So when the baby reached you, where the was diagnosed, right? Patient saturation 82%. So suppose generally now this you did not have an echo report, the baby was just referred to you, baby is blue. So what are some of the things you will consider to rule out cyanosis? Like what are some of the causes for cyanosis, central cyanosis in newborn babies?
Central cyanosis in newborn, we would approach like the at least considering narrowing down to the three pathology. The first one will be the some pulmonary pathology without any high PA pressure or PPHN. Second one is the classical cyanotic congenital heart diseases, and the third one is we are dealing with the kind of the PPHN. The three different scenario will be there in the PPHN. There will be the main thing was the labile saturation, but there will be saturation will be higher with the giving the oxygen. In the cyanotic heart disease, even after giving the high FiO2, the baby will not come up, and the duct dependent lesion will there will be significantly presented with the significant shock kind of thing. And in the condition like the only pulmonary pathology is there without any PPH, and that in that giving the oxygen will be almost done the work, and increase the PO2 more than 150. And with that, for the clinical examination, we can go for the RS examination as well. And another is
for completion of the answer, what are the other things you will consider? So you said congenital heart disease, you said PPHN, you said pulmonary cause, right? Any other thing you will consider the cyanotic? Like you don't know this child is PPHN, the child is just cyanosed. What are the other things you will consider causes of central cyanosis?
Under the central cyanosis, one can be the methemoglobinemia can be there. Otherwise, we can consider some IEM. Otherwise, baby is due to crash due to the severe sepsis. That can be the cause. This kind of some cases with central cyanosis.
Right. So even airway anomalies.
Yes.
So whenever you have a child with central cyanosis, you start from the top. So airway anomalies are also there. Any neurological also causes. Suppose a child is continuously seizuring, and hypoventilation is there also. So just to complete the answer, you have to state all the. So this child came to you, and can you see the X-ray? Can you read the X-ray a little bit in detail?
Yes, ma'am. The X-ray is in the
X-ray.
Yes, ma'am. X-ray is in the AP view, with there is a significant bilateral fluffy opacity is there. Otherwise, there is the ET tube at between the T1 and T2 vertebra, which is as the appropriate level. USC at between the T6 to T9. The UVC is quite lower side than the desirable. Like it should be at least 1 centimeter above diaphragm, but it quite at the or the below the level of diaphragm, which is quite lower. But that's kind of thing is there.
This baby was in high frequency. So for adequacy of high frequency, how would you how X-ray would help you to decide whether your high frequency parameters are okay for this?
If we are giving the appropriate MAP, then at least there is at least 8 to 9 ribs should be expansion of the lung should be there. Otherwise, we have to increase the MAP accordingly. That.
So have you heard this thing called recruitment strategies in high frequency? Suppose you had a white lung and you had to recruit the lung. So what is that recruitment strategy you do in HFO?
Yes, ma'am. In the recruitment strategy, we have to increase the MAP like slowly 1 to 1 centimeter at 2 of the MAP has to be increased till the baby's FiO2 requirement going to decrease, and as well as the X-ray as well as clinical signs of the lung expansion will be there. So by we have to recruit the lung. Like if we have done the suction of the baby, some pathology will be immediate collapse of the lung. In that, we have to perform the recruitment maneuver, like increasing the 1 to 2 centimeter of the MAP slowly till to decrease.
So basically, you have to look for FiO2 requirements. So once it starts reducing, you recruit it. And then some authors say that you need to de-recruit also and then go back. So recruitment strategy is to be used. Okay. Can you also show the EG blood gas? How do you read a blood of this baby? There are all the blood gas.
Blood gas. Yes,
The first blood gas that you saw in the child.
Yes,
the first one.
Yes, first one was the when the baby was received. At that time, the significant respiratory acidosis with the 54 PCO2, with there was the PO2 on the lower side 57, and considering it MI was 28, AADO2 was 432, which was suggestive of the severe respiratory hypoxia and distress.
Okay, so do you think this is a compensated respiratory acidosis, uncompensated, partially compensated? How do you decide that?
This is uncompensated respiratory acidosis because though there is the bicarb is within the normal range, but pH is still acidotic. So kind of partially compensated respiratory acidosis.
So uncompensated. So basically 7.1 is uncompensated, but you have to compensation. Obviously, this is not getting compensated, right? Bicarb has to go in which direction once there's respiratory acidosis? What will happen to the bicarb comes to respiratory acidosis?
Bicarb have to be on the higher side, in the positive side to compensate the respiratory acidosis part by the metabolic alkalosis.
Yeah, okay. I think we have 4 o'clock. I just want you to tell me, before we do all the INO and everything, a very big role of supportive care, correct? When you have a baby with PPHN. So tell me some of the aspects that you will take care of before you actually start the actual treatment for PPHN. So what are the supportive care aspects for this baby? You would think
Yes,
first.
supportive care will improve over the routine care. First is like we should avoid the excessive noise, avoid excessive light to the baby. Otherwise, the supportive care we should at least manage the metabolic disturbances should be must be avoided. Like the metabolic acidosis should be avoided. We should proper provide the intravascular volume by giving the if required, then the IV fluid, increasing IV boluses we should give. So ultimately, and the sedation is also the important part to prevent the worsening of the PPH. And we, as per the routine, different center protocol, different sedative has been given. As in this case, we have referred with the injectable fentanyl.
Yes, and all you should not forget the basic things like temperature, sugar, perfusion. All these things first have to be taken care of. Sepsis, if there is, it has to be taken care of, and then you move on to your actual. Yes, Dr. Shwetal, do we have time or?
No, we have to wind up. So,
right.
Any feedback you want to give to Bhavya for his coming
I think
exam?
Bhavya did a very good job. Yeah. I think if he goes to the exam, he'll do well. Yeah, he knows his topic. And
Sandeep, Dr. Sandeep, do you want to give some feedback?
Ma'am, two things. I mean, I would like to congratulate the Department of Pediatrics at Baroda Medical College for instilling good basics into him. And again, I would like to congratulate the Urban Newborn Care Center for more polishing his knowledge. And congratulations to Bhavya. He has done a very good job. I mean, again, I mean, if I look at my this thing training, I mean, I was nowhere close to him when I was at his stage. So very good. Keep up the good job. Yeah.
Thank you, sir. Thank you, ma'am.
Thank you so much, Dr. Kavita and Dr. Sandeep, for such a great interaction with Dr. Bhavya to sharpen his skills and make him ready for the final battle of IIP fellowship exam. Thank you so much. Thank you, Dr. Binoy, for such a great mentoring of Dr. Bhavya. Bhavya, really, you did a great job today. Thank you so much. I think on behalf of Kunal only, I would like to wind up the session. Rutuparna,
Yes,
thank you,
ma'am.
Dr. Vijay, for being with us. Rutuparna, we can wind up the session. Thank you.
Thank you so much, ma'am. for extending us the opportunity to host the session today. And I hope you all had a seamless experience. So thank you once again for sharing such valuable insights, and looking forward to host you again very soon in another interactive session in the near future. So with all your permission, we are signing off for today and looking forward to host you again soon. Thank you, ma'am.